Greetings, everyone, and welcome. I'm Meg Dorsey, a CIC board member and chairperson for the CIC Education Committee, and I will be your moderator for today's webinar. The California Immunization Coalition hosts education hours throughout the year on immunization-related topics to help our colleagues stay up to date on important news and information in the world of immunizations. Today's program will focus on a not so new, but perhaps not so well understood and very important public health resources, that being community health workers. As a public health nurse myself, who has been bumping around the public health environment for decades, I don't know as much as I wish I did about community health workers and the important work that they do, and perhaps you feel the same. So thank you for joining us today to hear from our distinguished speakers. Following today's webinar, a recording will be available on the CIC YouTube channel, which you can access via the immunizeca.org website, which is immunizeca.org. There you go. If you are unfamiliar with this feature on the CIC website, I encourage you to check it out. Cameron has done some recent improvements. It's just a really great spot to visit. And there are many archived webinars that you might find interesting. So now I would like to provide a brief introduction for all of our speakers today. Daruni Somseneth is the secretary of the board for the California Association of Community Health Workers, along with Lucia Gonzalez Cloud, who is vice president of the board for California healthcare workers. The mission of the organization is to promote sustainable integration and professional recognition of the community health worker workforce through partnerships, leadership, development, education, capacity building, community organizing, and policy advocacy. And that's a whole lot to do. Lucia Gonzalez is a community health worker with over a decade of experience. She champions the community-based model and intention of the California health workers globally. She's employed at a diabetes treatment center where she assists patients and their families in developing personal empowerment and disease management skills. Lucia is an active board member of the California Association of Community Health Workers, where she elevates policy and workforce opportunities. She is also completing an MPH in global health to further her passion for community development, health equity, and social justice. Our next speaker will be Maria Lemus, who is the founding executive director of Vision y Compromiso, a nationally respected organization dedicated to improving the health and well-being of underrepresented communities, specifically supporting promotoras and community health workers in their efforts to achieve healthy outcomes and dignified lives for Latinos who endure disproportionate rates of health disparities in both urban and rural communities. Prior to Vision y Compromiso, Ms. Lemus was active as a community consultant to local community organizations. She has 21 years of management experience in the Rural Health Division of the California Department of Health Services and the AIDS Office, City and County of San Francisco, as well as the California Department of Corrections. At the close of the program, we will hear from Brandon Silva, Master's in Public Health and Workforce Manager for United American Indian Involvement, who will give us more of a boots-on-the-ground perspective of the important work that community health workers do in the tribal setting. Brandon is a dedicated workforce development manager based in Los Angeles with a profound commitment to serving the American Indians and Alaskan Native communities of Los Angeles and Orange County. He has made a significant impact in improving the social determinants of health over the course of his career. Brandon's journey with United American Indian Involvement, Inc. spans 5 years, during which he has passionately worked to uplift communities with a particular focus on the Native community. He holds a Master's of Public Health from California State University, Los Angeles, specializing in urban health, which equips him with a deep understanding of the complex challenges faced by urban populations. So our first speakers today will be Daruni and Lucia. Please begin your presentation, and thank you all so much for being here with us.
I'm going to see if I can, I see, I can share screen now. Well, thank you for having us this morning. I realize we have many wonderful speakers. So Lucia and I will be speaking for about 15 minutes, and then we'll move on. So first, I want to say I'm going to give the brief history of community health work in the country, just to give a background, and then Lucia will expand on some of the roles that CHW can play in immunization. So for those of you who have not seen the definition of who community health workers are, is this. So community health workers is a frontline public health worker who is a trusted member or it has an unusually close understanding of the community served. This trusting relationship enables the worker to serve as a liaison, a link, an intermediary between health, social services, and the community to facilitate access to services and improve the quality and cultural competence of service delivery. So this definition was created through a special interest group from the American Public Health Association, and I believe it was adopted in, I want to say around 2009. And then through CHWW, which is the National Association of Community Health Worker, which I know Maria is involved with, they refined the definition here. Oops, and I am gonna. And so CACHW, which is the California Association of Community Health Workers, is fairly new. And our vision is to create a multicultural, inclusive community health worker learning collaborative that advances the CHW role and scope of practice and amplifies their voices in achieving health equity and social justice within the full spectrum of practice settings in California. And our mission is to promote sustainable integration, as mentioned earlier, to recognize the work that CHWs contribute to the public health as well as social service programs. Oops. And I apologize, I have to move my thing. So just a brief history of who community health workers are. One could say community health workers and promotores have been around for, since there were neighbors that wanted to help one another, and so this is from the textbook Foundations for Community Health Workers, and particularly from the chapter written by Lee Rosenthal, who does a lot of, workforce development and policy research on behalf of community health workers. So community health workers came about, roughly, paid community health workers was recognized in the 1950s, particularly around establishing a period where, and I think one of the first probably paid CHWs were from the Native American tribes and, helping also families, migrant farm workers at the time. And then, of course, it continued, that profession continued to grow into the 1960s with the war on poverty that the government had. And particularly for a lot of our health centers, our federally qualified health centers, many of them came about in the early 70s, the late 60s, and they had community health workers at the time being hired onto it. And then finally, as we move into the late 70s and 80s, more CHWs were being hired for things like a vaccination and immunization and maternal and child health. And of course, as we get into the 80s, there was also a lot of CHWs coming in to do tobacco cessation and HIV education, as well as testing. And I myself, when I was CHW, was on 5 different grants. And a lot of those grants were due to money, public health money, trying to on education and prevention. And then as we move towards the 2000s, there is now an increased recognition of the contribution that community health workers and promotores provide to our community, as well as the health and social services sector. And so there is now, continue to be funding and more advancements in terms of education, as well as workforce development. Hold on. I apologize. I'm not able to advance my slides as well as I would like. Okay, here we go. So community health workers go by many titles, and through a website, we show that there are over 250 titles that CHWs go under. And the CHW term, or community health worker term, is an umbrella term. And so underneath it, we have promotores de salud, community health representatives, as we know, care coordinators, patient navigators, health advocates, community health outreach workers. So the list goes on and on. In California, there is a more of an inclusive term, and we see this in the term CHW/P/R. The P stands for promotores, and the R stands for community health representative, which are in the, the tribal nations. And so as we, as I mentioned, there's been paid work since the 1950s, maybe a little bit before that. And as more and more of this work, more and more of us finding work and trying to sustain a living through this work, one of the things that have always come up is, as you mentioned, who are CHWs and what are their roles and what are their functions? And so I believe in the, roughly around 2013, 2015, a group of CHWs as well as allies came together and started to create, a uniform list of what are the core roles and what are the core competencies or skill sets for community health worker. And we reference this as the CHW Core Consensus Project, and you might see it in many different publications as the C3 project. And so the roles are these, cultural mediation, providing a culturally appropriate health education information, as well as care coordination, coaching, social support, advocacy, outreach, and then recognizing that CHWs can also play a role in evaluation and research. And of course, the competencies kind of match to the roles. And being key is communication, building interpersonal and relationships, as well as building capacity within the communities that we serve, in addition to advocacy skills, and then of course, research and evaluation. So we know that since I think what we've seen in California is the rise in the usage of CHWs in working with community and the recognition that comes with that. And that really came to be during the COVID, pandemic, right? And we see that community health workers were key in really working on addressing the social determinants of health that impacts communities most by COVID. And many programs, paid and unpaid, public health nurses were partnering with community members and other community health workers and promotores to look at how can, to educate community members around vaccine usage and uptake. And we saw that there is a strong correlation between trust as well as understanding of that information tied to vaccination use. And we earlier I mentioned that many CHW paid positions were tied to immunization and vaccination earlier in the career development of CHW, and that continues to be the case. And as we look at the health of our community, of course, the focus is now on the root causes of what's happening in our community and looking at the social determinants of health and looking at prevalence and also how is it showing, how are all the different, I guess, infections and diseases are showing up in the communities. So we know also that in general, that for community health workers, there's been a lot of studies on return on investment, and we've shown that CHWs have a larger, have a larger return on investment when you think about, working with community members and also looking at health outcomes and also decreasing health disparities as well. With that recognition also comes more opportunity. In particular, Gavin Newsom, our governor, has proposed that as part of their, the state's drive to work on health equity or improving health equity within the, our marginalized communities, he proposed that he wants to fund opportunities to train 15,000 community health workers by 2025. And part of that piece, so there are many things happening in the state. You probably also heard of the Medi-Cal benefit that became live on July 1, 2022. That's also driving the growth in terms of the attention that CHWs and promotores are getting, as well as community health representatives. And of course, there's also the CalAIM initiative as well in terms of transforming Medi-Cal to make the program more equitable and coordinated so that it's person-centered. In addition, after COVID, there was the CDC grant around supporting community health workers for COVID response and resilience communities, which is sometimes seen as the CCR 2109 grant. And that in itself, in California, we saw 7 grants come to California. And then recently, there's also the HRSA funding for apprenticeship training for CHW. And I believe in California, there were 5 grants. And on average, those 5 grants were about $3 million apiece. And of course, there's also a lot of funding, not just public money, but also private foundation money. And in particular, the California Healthcare Foundation have put a lot of investment into advancing the workforce, as well as the recognition of community health workers, promotores, and community health representatives. They have a policy coalition. They also funded 4 regional capacity building hubs, which were in Alameda County, Inland Empire, Central Coast, and San Diego. Oops. And now, and I'm going to see if I can. Oops. Apologize. Let me go back one more. So in general, you can see just through the just brief slide about just what's happening from year to year. You're seeing an increase in terms of recognition and acknowledgement, and also the need for more CHWs, more promotores, and more community health representative. And I will share the slide with the group at a later date. But I want to. And by the way, there's also in California, there's talk of course, perhaps maybe creating a California Community Health Worker certification, or what's called a Medi-Cal certification. Every CHW without certification can do this work, but to get Medi-Cal reimbursement, they would have to be state certified. And that's still up in the air in terms of when the state will go live with that particular policy. So with that, I know I speak really fast because I wanted to get through the history of this as a baseline information. I want to turn it over to, our board vice president, Lucia Gonzalez-Cloud. Lucia?
Thank you, Darani. Good afternoon, everyone. I'm really excited to be here with you. Bringing the voice of the community health worker along with the other participants to this presentation. And the question is, why do we need community health workers that be integrated to the public health and the healthcare system? And I can answer from the voice of the community health workers because community health workers are experts in the community needs and are representative of them than sharing their knowledge with the clinical and public health experts to improve outcomes. Community health workers her primary focus is in the social determinants of health and patient empowerment. When we think about the integration, we have doubts and difficulties in both sides. Some community health workers see difficult how they go into work in a public health setting or a healthcare setting. At the same time, healthcare providers are in the process to learn how to work with community health workers. I can share by experience at one of the level 1 hospital here in California that it can work well if community health workers are invited to the table together with the other health providers to make the decisions in relation to the well-being and improvement of the health of the patients and the family. Because when a person is sick in the family, everybody is affected, especially participants who are for undeserved communities. When community health workers work in close collaboration with the health providers and the public health experts, for sure, we're going to have better results for these patients, for their families, and for the community. Related with the training of the employers, as a community health workers, we hope our supervisors be health providers or public health experts who had previous experience and work with community health work in the community base, in education, or in healthcare areas, and willing to learn and understand the view of the community. Usually, in a health system, most of the activities are very fast-paced. Even though the health providers and public health experts, they do a lot for the patient and participants and putting their expertise in the improving of the health and well-being of these patients as participants, they do not have the time to develop a more deep relationship with the participant and with the family. And saying that there is no time to address the social determinant of health. There is the community health worker, a crucial, vital piece in the team to address these needs. When we talk about the supervision, we believe community health workers, when they are well trained and have the opportunity to grow professionally, they can also be later on supervisors and supervise the community health workers as other health professionals. When we're talking about the recruitment, not only focus in the competence or skills, but also in the qualities the community health worker bring to the team. Competence and skill are possible to learn and develop. Qualities is very difficult. Something that identifies community health workers is their compassion, their willingness to do much more that is expected and is paid. How many community health workers work extra hours without payment, work weekends without expecting any reimbursement for their time and their dedication and expertise. In fact, many community health workers invest their own financial resources to help the families where they work. Talking about support and retention, health systems, including the public health, are called to develop ways to motivate community health workers to be with them for a long time, but also receive the support they need. Instead to have a supervision that will rudimental, a supervision that will help them to grow personally and professionally, determine which areas this community health worker is doing great and can develop to serve better the community and their own collective of community health workers, also be better team of the public health. Community health workers need to be trusted in order to be allowed to write notes in the software of the healthcare systems, for example, Epic. And these notes have to be read for the rest of the team, because there they will have an input from the community and a feedback about if their treatment they prescribed was understood for the patient, for the participants, or if the indications were clearly followed. We have many times discovered that the patient participant didn't understood and overdose and ending in the intensive care, or in other cases believe that medication is not important and deciding to stop. For example, in diabetes, giving that a situation that the participant can lose the vision, or in other cases an amputation or other serious situations. CACHW is an organization that offers an impartial, neutral, safe space for all community health workers. Community health workers that work in education, that work in healthcare, that work in community-based organizations, that work in research. All are welcome. We have our own organizations where we belong, but also CACHW offers a neutral place for all of us and is the voice of all community health workers in California, offer a regional representation and allow us to share our best practices and receive technical assistance in different areas. Community health workers play several roles in immunizations. I'm only going to mention a few of them due to the time. They outreach communities that are often excluded and labeled hard to reach. Yes, the clinics and the healthcare systems are there with immunization and other services, but community health workers go door by door to reach this community and assist building confidence by addressing the myths and misunderstandings about immunization information as well in other areas. Community health workers increase the coverage on immunization through health education and that is culturally appropriate and also through health promotion. Community health workers are offering excellent peer support because they understand very close the needs of the community through life experience or a close experience. They offer a holistic approach to the needs, to the health needs of the community, accompanying them emotionally, giving the support the community needs, especially, for example, when they lost a relative due COVID or other situation, giving the support is needed at the right moment. They build technological skill by teaching how to make appointments, how to have a telehealth and promote other changes. But also we have serious challenges, the uncertainty about funding positions. The community health workers, they don't know what is going to happen with them with the grant finish. And also the community can lose this trust when they don't see more the community health workers in the communities. Wage inequality with low salary and also insufficient resources. As a community health workers, what we want also is more training that allow us to give better services to our communities. Finally, I would like to invite the allies and community health workers to join our monthly community of practice the first Friday of the month and sign up for our newsletter where all are welcome. Thank you.
Thank you. Thank you so much to Daruni and to Lucia for that wonderful presentation full of useful information. Before we move on to our next speaker, I just have a couple comments that I want to make. I realized in the very beginning of our program when we were doing housekeeping, I failed to mention the process for asking questions. If you have technical difficulties at any time, please use the chat button and Cameron will be with you swiftly to assist. If you have questions, you can type them in anytime throughout the program by using the question Q&A section on the button on the bottom of your screen. So please feel free to type in questions at any time. And one question that I just want to address before we move on, because it's somewhat universal, I regret that we do not have Spanish translation for the content of this program in real time today. So I apologize for those that presents a problem for. We will look into the possibility of perhaps making this more language accessible in our archived program. So now I would like to invite Maria Lemus from Vision y Compromiso to begin her presentation. Please go ahead, Maria.
Thank you, Megan. Thank you, everyone, for the invitation to join this conversation. I'm here to share what we call the integrating promotoras in the community transformation model. And if we can go to the next slide, Cameron. There we are. So the promotor model, and I'll be speaking mostly about the community promotor model and community health workers and community leaders. Promotores are throughout history have been known. We can look at the Felders in Russia, we can look at the barefoot doctors, we can look at in China and in Latin America. So I just want to contextualize that the promotor model has been popular throughout history, and that it was brought to the United States in the 60s through the war on poverty and really formalized in a CHW, which is a community health outreach worker. That's where I first met promotoras were at CHWs when I worked at the AIDS office, and it was a very successful model for doing outreach and education. The next one, please. Also that the World Health Organization and the Ottawa Chat, they really have supported the work of promotoras across the nation. I mean, look at the Africa, the work that's being done there and in other countries. It's been internationally recognized. All that is to say that in the United States, and it has not necessarily been recognized until recently. The next slide. So when we talk about promotoras, who are we? This picture is a little depiction of who we are. We're younger, we're older, we're Afro-Latina, we're from many Latin American countries, we're men, we're women. However, we are primarily a woman workforce when you talk about the promotor movement. Next one, please. And what we have found is that promotoras are an effective catalyst for community change. We talk about who they are, but Vision y Compromiso is now in its 24th year. And we came together with a few of us who started realizing that what we do is we go out in the community and we provide information. We're that link to the community resources. 24 years ago, promotoras were primarily volunteers. They were affiliated with some organizations or churches or other kinds of organizations like that. And really it was acting as those liaisons, acting as those natural helpers. My mother was a promotora. My grandmother was a healer. So I grew up with that history of knowing what it is that we did that was an important contribution to our community. And it does extend beyond the health. Vision y Compromiso does not really talk about the physical health only. We talk about the big health, which includes the social determinants. Anything that affects a family, affects a promotor, affects Vision y Compromiso. Next page, please. So why is it that we got into disparities? As we started to branch out across the state and our regions were formed, promotoras really wanted to know more information. They wanted to take it out into the community. We started getting involved with prevention efforts. At that time, it was HIV, but it was also diabetes, hypertension. And we started giving information and then developing programs on how you can utilize that information. What kind of prevention activities, what kind of maintenance and adherence activities could we do? We knew that promotores provided all these services and information at a very cost-effective rate. So you may hear the ROI, return on investment. That was the early justification for a promotor, that we could reduce the number of visits to the emergency room. We could reduce hypertension, A1C, because of the activities in the community. And by keeping appointments, increasing access, decreasing the effect of barriers, those are some of the things that we were known for. And if you look at this chart, it really is overlapping with community, the healthcare systems, families, and communities. And promotoras are at the core of this. Next slide, please. Oops, there we are. And so we started then talking about health equity and social determinants. Our vision is Hacia una vida digna y sana, which is working towards a dignified and a healthy life. Everything that Vision y Compromiso is founded on, in particular the network of promotoras and community health workers, really stems from this, that we are working towards a dignified and healthy life, which means that everything that involves a family, that involves an individual, we're working towards. Most recently, that includes jobs and equity. You'll see that through these, they're very similar to social determinants, and income, education, exposure, all these things we either have programs for as community-based organizations, or we develop a relationship with agencies that can help provide that information in the community. Right now, probably I think the most important one is income, which is jobs. Vision y Compromiso is very active at the state and the national level, has been active in the APHA. When we talk about the definition for community health workers, I was in those meetings in the early APHA days, and I'm one of the founding members of the National Association of Community Health Workers. And Vision was also in the C3, early C3, the development of the C3 guidelines. So the promotor voice has been active in all the discussions, gosh, for 20 some years. And still we're subsumed under the community health worker definition and the community health worker title. And we say we're just slightly left of the title because it doesn't quite apply to us as promotores, because most promotores are associated or affiliated with community-based organizations. Now you would say, well, isn't that a good thing? Because we have the community benefit and we have CalAIM in California. Well, it would be, except for CalAIM and the community health worker benefit in particular. Those really apply to positions that are affiliated or can get reimbursed through Medi-Cal. And most community-based organizations who have or work with promotoras are not able to apply for those funds. So there still is not a direct stream of funding. It is for the community health worker who's affiliated with a clinic, a hospital, or a plan. And I think that's the distinction I want to really, if you can take anything away with you today, is don't assume that the same applies to agencies, community-based agencies that have promotoras working or volunteering with them as it does for an agency like a clinic, plan, or hospital. That's one of the big issues that Vision y Compromiso is advocating for right now, is really looking at the whole continuum of service in agency and in community, and giving recognition and support to those community-based organizations. For years, community-based organizations and promotoras have been that support system for our community. If I walk out the door and I'm diagnosed with diabetes and the doctor says, exercise and eat better. So I go home and I don't have a resource. I can't afford a gym. I can't exercise in my neighborhood because it's maybe not safe. And I don't know how to change my chicharrones into a healthy food. So what do? I continue to do what I do, and I get worse. But there are CBOs that are right nearby. I can go. They have an exercise program. It's free. It's in my neighborhood. They have a cooking class on how to adapt my food so that it's healthier and tastes good. And they have a support system that somebody will walk with me. Somebody will say, Maria, come, let's go walk. No, let's have a cafecito, but maybe do it not so much. Let's do something a little different. Or eat your beans. They're really historically, we eat beans and maize. That's very healthy for you. So the CBOs have always been there as a resource. And what we are saying is recognize the community and recognize the community promotor as being that partner in health with all the other institutional groups. Next slide, please. These are some of the roles that we play. Prevention is prevention and control, treatment. The provision of essential drugs is important because we had a pilot project with Vision where we actually worked with the family to understand. We certainly are not pharmacists, but worked with the family to understand what the medication was, the time that they had to take at and keep with the rules of that medication and the guidelines. That was really important. So now we're into navigation and adherence. We're into education and different levels from children. We have a family, friends, and neighbors program, informal caregivers. We do say that there's a role for promotoras in programs from preconception to death. If you think of the life continuum, there's a role for promotoras. We have a family early childhood piece. We have a caregiving and death and dying piece, and everything in between. whatever affects a family, the socio-ecological continuum is where a promotora can fit, and a promotora best fits in a community-based organization. The rules, the hiring rules are different. The training is different. We have numerous papers that we've written on workforce and integration of workforce with guidelines for employers on how to recruit and train and keep the employee. We also have a lot of papers on what is the promotor model. Please go to our website and look at the papers that we've written. The most recent one is the COVID impact on promotores, the economic impact of COVID on promotores. And you'll see that while promotores and community health workers were highlighted as essential workers during the pandemic, there were a lot of downsides to it. We still were not classified within the community health worker spectrum, even though community-based promotores were out in the fields day to day. They were without consideration of their own health. They were determined to provide as much support to the community as possible. And in many instances, they themselves were not able to get some of the benefits. For instance, vaccinations. Many of them were not able to get vaccinations because of the guidelines that were primarily for the community health workers. The next slide, please. This is the circle is really our goal, to increase individual and family health. And we do that by building egalitarian relationships. Well, what does that mean? That means that we go out with espíritu de servicio, with our willingness to volunteer and to support our community. We learn as much as we can on different topics. We share that information either through one-to-one or through local convenings or to trainings. We just had a Bay Area conference, a regional conference of close to 200. It was an amazing day of sharing and learning from all over the Bay Area. Our annual conference in October, we bring together nearly 1,000 promotores and community health workers for 3 days of sharing and learning and building community. That sharing of information across disciplines, across agencies is so important. It helps to lift up who they are. It helps to motivate them to really get more involved. And also in advocacy terms, they start to advocate for themselves as well as to advocate for their community. We see it now with our young people. We've been training youth across California, and because they see their parents hired and working for an agency, receiving benefits in retirement, they now see it as a profession. The world is open now. It's so much opportunity for our young people as there is opportunity for those in the community who have the espíritu and who want to help. And it motivates the community participation to be participant in their own well-being, they're locally as well as statewide. Next slide, please. I encourage you to look at this paper. We did a research paper with many organizations. It really talks about understanding the model and the care team and looks at training. What kind of training do you need to not only recruit, but to maintain your workforce, and how to look at the workforce in different ways, and how to recruit and how to train. I encourage you to look at this. This is on our website. And the next slide, please. So this is our challenge, and I'm almost till I just have 1 or 2 slides, but this is our challenge and our opportunity. It's not that the promotora must fit in the organization, but the organization must fit the cultural values of the community. That organizations who truly understand promotores use popular education methodology appropriate for the community transformational model. Core competencies are linked to the model. System readiness means you already have in place values and principles to support the model, and you understand what that person needs. We train on that. We train on both sides, the employer and the employee. We want to make sure that the employee is happy going into that organization and that the employer is happy and with that person that comes in to that new environment. It's a win-win for it. Our hope is that it's a win-win for everybody. The next slide, please. We do our network trains promotoras across California. We have a Promotor Institute, workforce training for promotoras, organizational readiness, technical assistance to organizations. We manage over, it says 30, but we manage over 50 projects, really to be able to show that a promotor can do most anything. A promotor can learn most anything. And then, of course, our advocacy and our policy that we're involved in now, representing thousands and thousands of promotoras across California and the United States. We now have a national network and national coalition building up the core of who promotoras are across the nation, that wherever there is a community of workers who have the heart to serve, and this is not just a Latino thing, this is any community. Those of you out there who are listening, think of your aunt, or mostly women, or your grandmother or your mother, who are always helping and serving. That's a promotor, that's the promotor model. And we're lifting that model up. We're lifting these wonderful people up, that they are not only necessary and important, but they will change our communities. The next slide, please. And here you see Hacia una vida digna y sana. That's what we work for, a dignified and a healthy life for all. I want for your children as I want for my children. And that's our goal here, is to lift up these experts, lift up these community experts who have always wanted to help in our community. Thank you very much.
Thank you so much, Maria. I feel very touched and very inspired by your contribution. Thank you. And now I'd like to invite Brandon to begin his presentation. Go ahead, Brandon, and thank you very much.
Hello, everyone. Thank you again for this opportunity to share about our Boots on the Ground program here at United American Indian Involvement. So we're based out of Los Angeles, California. We've been in existence since 1974. So this marks actually our 50th year providing services to the American Indian Alaska Native community. So again, I think it's extremely important to discuss our mission and vision. So I will read this in verbatim, but our mission again is to promote and support the physical and behavioral and spiritual well-being of American Indian Alaska Natives in the urban Los Angeles area by providing comprehensive integrative services that focus on all age groups and incorporate American Indian Alaska Native cultures and traditions, right? That's very important because this mission here is what's guided our program, specifically our community health worker program throughout the years, right? So it's guided us, it's gave us our understanding of what and why, who and why we serve this community. So some history about our organization. As I mentioned, we started in 1974 in the streets of Skid Row. So if you're not familiar with the landscape of Los Angeles, the downtown area, Skid Row area is a predominantly unhoused community. And our organization began there, providing services to those American Indian Alaska Native families that were relocated to that area. In 2004, we celebrated our 30 years of servicing this community in the Los Angeles area. But what do we see in 2020, right? We saw the onset of COVID-19. We saw the pandemic rise and begin to destroy the community in its essence, right? The families, health. We began to see exacerbation of diseases, disparities that were always there, but we began to see even more of a burden on the community. So our community here, our organization, actually was a recipient of is still a recipient of the CDC, CHW for COVID response and resilient communities. It began the foundations, you would say, or the pillar of our program, our CHW program. And so present day now, again, we've been able to move into a new facility where we began to expand several other services for our Native community here. We're able to offer healthcare, so clinic, soon to be a dental program, also our mental health services, our substance abuse and prevention, also our mental health, behavioral health, and youth services, and finally our workforce services. So our CHWs have been able to integrate into many of these programs. Again, at the start of the onset of 2020, there was a huge need, a huge gap that, as many of our speakers mentioned, the CHWs have been able to continue to glue those services together, to be that resource for the community, to be able to share what is the exact need or resource that that individual might need and not know where to get it. So again, we like to think about this, right? Well, we throw out the word community. We say, well, we're community health workers, community health representatives, navigators, etc. Right? But what does community really mean, right? And I want you to think about it as I continue on these slides. But again, community, it's your narrative. You shape that into what your beliefs, your worldview, your ideas, your resources, your neighbor, and your community member, right? So this is what binds us together. This is what creates our CHW program. And as you can see here, you know, it started in 2020, but now we've been going for 4 years, and it really started with our outreach efforts, right? It started with us getting out there in the community, sharing those resources, whether it was a car seat, whether it was a mask, whether it was resources for our organization, whether it was just letting them know that, hey, our organization, our CBO is here for you, and you are welcome to come in and receive those services from individuals that are you, that look like you, that have been with you, that have done the work, that are part of the community. So again, some history, what did we see? Well, COVID-19, again, these disproportionate impacts, you know, our social determinants of health. There was inequities that we began to see exacerbate, right? These underlying medical conditions that weren't being addressed. Well, because COVID-19 was at the forefront, right? But again, chronic disease, alcohol, drug use, mental health, unemployment, right? Cycles of poverty, homelessness, this health burden, again, began to be exacerbated, and the CHWs were the pivotal force in bringing these services to the community and relaying a message that was needed to be shared and understood in a way that, again, not everyone could have understood, right? We were getting messages left and right. We were saying, stay home. Now you have to isolate. Now you have to take this vaccine. Now you have to do this. Well, our CHWs were able to relay that message, to share it in a way that it was easily digestible and understood, right? But the other thing that we did see in the community is these vastly undercounted numbers, right? This misrepresentation because of misclassifications, identity, race, but Native Americans were 3.5 times more likely to have COVID than non-Hispanic whites, right? So this stark difference that we were seeing, but it was and misrepresented in the media and in the outlets of information. So a little bit about our program here, where our program was consisted of two groups, right? We're one whole community health worker program, but because, as we mentioned, the funding sources, you know, that was the way that we were able to structure our program. So we had, again, the CDC program, which was part of our grant for COVID response and resilient communities, but we were also partnered with our local health department, right? So the LA County Department of Public Health. And what we did is we merged both of those, and we were able to work together to share those messages that we were receiving from the federal government, while we're also receiving from our state and local jurisdictions, so that we can promote our services and promote the health within our community. We were contact tracing, we're including vaccinations, we were ramping up our COVID-19 responses. And we were also leveraging other grants, right? Other funding sources. So we were able to partner with the California Rural Indian Health Board to provide incentives to our community. And what we did is, well, we wanted to go bold, right? We gave our community members $100 for a vaccine, right? And we saw in numbers increase. We saw vaccine intake increase. We saw that hesitancy erase, right? Because our community health workers were able to relay that message in a comfortable and inviting space. Our CHWs, again, how we structured that in our organization, one of our services here is our health project. And our health project is our overall health program. So our community health workers are entwined into these services providing home visits, assessments, referral services, outreach, workshops, you name it, we're integrated with our organization to provide these services. Again, as we heard, some of our roles, educating the community, providing this message, providing a resource, a linkage to the community. And I apologize, I'm speeding through the slides to try to get as much as I can, but COVID-19 response, right? We were trusted messengers. We built that relationship. We built the trust. We were vaccine advocates. We built the capacity within our own organization. We ensured that the care was still being delivered to our community members. And we were addressing those social needs that were not being addressed. So what did we seen? We also were able to attend over 50 events where we were relaying a message to the overall community. We were able to reach over 60,000 plus people. And these numbers have increased from these numbers, but we were able to accomplish more than 800 referrals, booster doses, second doses, first doses, hundreds and hundreds of community members that we were able to serve. So here are some photos of our community. Again, as I said, it was a multi-team purpose effort. We were out in the ground. We were making sure we relayed all of our message. We were getting groceries. We were distributing sanitizer, masks, cleaning supplies to our elders. We were making sure we met every need we possibly could. But again, we were rooted in our core competencies, right? So the C3 project was our guiding principle, right? Is how do we increase these skills for our CHWs so that they're, one, competitive, they know what they're doing when they're out in the community, they can provide solid facts and tie that with their personal experience. So again, what do? We increased our social determinants of health, right? On a one-to-one basis with our community. We increased resources to employment, mental health and addictions, healthcare. We were making sure that our clients were understanding everything that they possibly could and needed, right? So we also decreased isolation. This was a huge, huge aspect, right? Because we are a community. We connect. We want to be with our elders. We want to be with our neighbors. We want to be with our friends, our coworkers, our community members. You name it. We were trying to make sure that that connection was still there within the community. And we were successful. We were successful in this. We were able to not only give our community members what they needed, but we were able to make a case for our community health workers to show that they were the glue in integrating our services. We saw increased participation in our services. Our constant communication between our CHWs and our different programming, we began to train, engage, and deploy our CHWs into the community. And we highlighted their lived experience as the key message to our community and our leadership here. But again, we stayed flexible. We understood that the task was significant, and we needed to pivot as we came along through our program. And what do we see now, right, is the Medi-Cal benefit. How are we accessing that as a community-based organization that serves Native American, Alaskan Natives? How do we access that benefit? So we're in the talks, negotiations right now to be able to address that and sustain our program. And CHW certification as well, right? That is what will, again, give us the key to access some of those benefits, but that doesn't stop our work. We will continue, and we have continued, and we're looking for new ways to partner and increase our ability to reach all community members that come in through our doors. So thank you again for staying in this presentation. Here's some information. I'm going to pass it back to to Meg here. Thank you so much.
Thank you so much to all of our speakers. What a wealth of information. And I also have to say, what a wealth of inspiration. So thank you all so much. I regret that we are at the top of the hour and we will not have an opportunity to address some of the questions that have come in. But just know that we will attempt to address your questions that have gone unanswered in email fashion, and we'll include what we are able to when we archive this program on the CIC website. So I just want to take a moment to encourage people to fill out the evaluation form, which will pop up at the conclusion of this program. It will pop up on your screen. We really appreciate your responses. The California Immunization Coalition produces at least 3 to 4 education hours per year, and we rely on, we count on, and we value your feedback for preparing these programs and improving them. So as we wrap up quickly, again, I want to heartfelt thanks to all of our speakers. Please feel free to fill out the evaluation form. And I also just want to quickly highlight upcoming education opportunities. The next education hour opportunity that's coming up is on March 13th. And it's a program about Back to the Vax, which will feature 2 mothers who were anti-vaxxers who changed their tune. It's very inspiring. And we also have a program coming up on February 22nd, which will address, it's more geared towards clinicians. It will take a look at symptoms, diagnosing and treating some of the vaccine preventable diseases that we just don't see very much anymore. So again, I'm sorry that we did not get to questions, but I want to say thanks to our speakers and a very big thanks to all of you for spending a portion of your day with us. Please remember to complete the evaluation, and I hope that you all have a wonderful rest of your day. Take care.